Good evening. My name is Renee Sanchez, and I'm the founder and chair of the Nursing Administration Alumni Advisory Council. I'm also a board member of the Myers Alumni Association. I would like to welcome you to the second annual Chief Nursing Officer Panel Discussion this evening. We are so happy to welcome four outstanding Chief Nursing Officers tonight. Dr. Deborah Elbert, Senior Vice President for Patient Care Services, Chief Nursing Officer at NYU Langone Health. Dr. Natalia Sinias, Senior Vice President, System Chief Nurse Executive at NYC Health and Hospitals. Dr. Carl Curtin, Chief Nursing Officer at the University Hospital in Newark, New Jersey. And my very own CNO, Terry Pando, Chief Nursing Officer and Associate Executive Director at Long Island Jewish Valley Stream of Northwell Health. Our first CNO panel occurred in February 2020 and highlighted the work of 5 CNOs who gave us so much insight into their executive leadership practice. The response to the program for the nursing community was so robust that we needed to change the site of the event to a larger auditorium at NYU Langone Hospital. The forum was honored with the Event of the Year for 2020 by the New York University Alumni Association. Little did we know that evening that in just a few short weeks later, these CNOs would be leading their respective organizations through the COVID-19 pandemic surge. Thank you again to Dr. Irene Masick, Dr. Kimberly Glassman, Dr. Frances Cartwright, and Dr. Roseanne Rosso and Dr. Tom Smith for inaugurating our council's annual event. The aim of the Nursing Administration Alumni Council is to keep the graduates of the College of Nursing's Administration Master's Program connected to the college and to each other for the purposes of sharing, refining, and extending on individual leadership practice. Everyone on the council is a proud graduate of that program and has studied with Professor Eloise Cathcart, the director of the program, and Dr. Kimberly Glassman. As alumni, we are grateful for the opportunity to influence healthcare through our leadership practice and for the special role we have as frontline nurse leaders in the lives of clinical nurses. I want to give a special thank you to Janet Griffin, Director of Alumni Relations at Myers, who provides us with the structure, support, and encouragement, as well as the other founding members and new members of the council who keep my vision of staying connected to the college and to other alumni from NYU Nursing Administration program alive. It is now my honor to welcome Professor Eloise Cathcart, the Director of Nursing Administration program, for opening remarks.
Hello, everyone, and welcome. We are expecting Dean Eileen Sullivan Marks to join us, and until she comes, I will have the pleasure of welcoming all of you to this program this evening from her and from me, too. So I would like to add, my welcome to our nurse executive colleagues and to all of you who are joining us remotely. We're delighted to have you with us. Expert nursing leadership is a bit about determination, personality, and technique, but a lot about character, virtues of authenticity, integrity, courage, generosity, skilled ethical comportment. Rules can't tell us how to be authentic, when to be courageous, how and when to be generous. We need to read the particular situation, accurately figure out what's going on, and know how to do the right and good thing in a particular circumstance with a particular person at a particular time. So, in the process of developing new nurse leaders, we can talk in the classroom about the character virtues. What are the characteristics of authentic leadership? Why is having the courage to take risks important? What the literature and evidence say about these things, but the student can't see it in the abstract, how it looks to be authentic, what it feels like to have integrity, why being generous is the right thing to do. Because it's the particular situation that calls up the character trait and makes it visible. So for the student to see what it looks like to be an authentic leader, the student needs to see authenticity lived out in the practice of the expert leader. And then the student can stretch his or her moral imagination to see themselves acting that way in a similar situation. My point is that developing new nurse leaders happens in part in the classroom and in a major way in the practice. And the people living out those character virtues every day, showing us how to be authentic, how to be courageous, how to have integrity, how to take safe risks, how to be generous in the most complex and challenging times that we're living in, are the expert leaders who have joined us tonight and their nurse executive colleagues. It is they who are our partners in the formation of new nurse leaders, and for that we are grateful. I am personally also grateful for the leadership and the wonderful energy and true commitment of this Nursing Administration Alumni Council for what they are doing to create a place at our college for reflection, dialogue, and examination of our nursing leadership practice. I couldn't be more proud and I couldn't be more pleased that so many of you have joined us in that journey tonight. Thanks for coming.
Thank you, Professor Cathcart. It is now my honor to introduce the panelists for tonight's program. Dr. Deborah Albert joined NYU Langone Health as a Chief Nursing Officer and Senior Vice President for Patient Care Services in April 2020, overseeing nursing for the entire health system. She leads and manages the nursing and patient care services organizations across the system in planning, implementation, and evaluation of quality, safe and efficient nursing and patient care with measurable outcomes. She has decades of leadership experience, always with a keen focus on patient outcomes, staff education and development, and strategic financial oversight. Dr. Natalia Sinias serves as a Senior Vice President, Chief Nursing Executive, and Co-Chair of Equity and Access Council for NYC Health and Hospitals, the largest public healthcare system in the nation, serving more than 1.4 million New Yorkers annually in more than 70 patient care locations. She serves as the clinical lead for the organization, directing more than 9,600 nurses and more than 970 social workers, as well as planning, overseeing, and evaluating all aspects of clinical operations, services, and nurse education to ensure the delivery of quality, safe, and standardized and cost-effective nursing care to patients in the community. Dr. Carl Curtin is the Chief Nurse Officer of the University Hospital in Newark, New Jersey. Previously, he served as a Deputy Executive Director and Chief Nursing Officer at Lincoln Hospital, a mental health care center in the Bronx, and as a Senior Vice President of Patient Care Services and Chief Nursing Officer at North General Hospital in New York City. Dr. Curtin has worked as an HIV/AIDS nurse practitioner since the start of the epidemic and continues to write and publish in his field. And Terry Pando serves as the Chief Nursing Officer and Associate Executive Director for Patient Care Services at Long Island Jewish Valley Stream Hospital. She previously held the same position at Staten Island University Hospital. Throughout her tenure at Northwell Health, Ms. Pando has held multiple positions in tertiary and quaternary hospitals, including Senior Administrative Director for Critical Care Emergency Services and Interim Associate Executive Director for Perioperative Services. Her leadership experience has focused on mentoring, employee engagement, transformational hospital design, and financial management. Kirsty Toussaint is the Senior Director of Nursing Operations and Service Excellence at NYU Langone Long Island campus and a doctoral student at Temple University's Fox School of Business. She is a member of our Nursing Administration Alumni Council and will be moderating this discussion this evening. At the end of the discussion, there will be a Q&A. You can submit your questions by typing them into the Q&A box. We will get to as many questions as possible before the end of the program. I'm going to turn the event over to Kirsty and our panelists. Thank you.
Thank you, Professor Cathcart, for setting the stage for our discussion tonight. And thank you, Renee, for that wonderful introduction of our panelists. I'm glad Debbie's able to join us. She's just having a little bit of technical difficulties, but we have her here, and as a true CNO, she's able to pivot and figure it out and get right back on track. So glad you were able to figure that out in, I think, record time, 30 seconds. Great job.
I just went into panic mode there for a minute.
I know, but we figured it out. Great job. All right, and just in time, really, we have, it looks like about 75 people in our audience so far is logged in, and I'm sure they're really excited to hear what you have to say. So let's jump right in. So the first question actually is to Dr. Albert, and then I'll have the other panelists jump in. What defines success in your role as a chief nurse, and more specifically, how do you balance the dual responsibilities of being a major organizational executive and then also leading the practice?
Well, that really is a great question. And I have to say first, it starts with how and who is defining success. But as you think about it more specifically, the way you clarified the question about really managing the role of a hospital executive as well as then leading the practice, I think for me, it comes down to staying focused on the big picture. Because when I really think about it, what's good for the patients and for the organization is good for nursing, and vice versa. What's good for nursing is good for the patients and the organization. And so I think bringing people back together, clinical nurses, non-clinical leaders, and really helping to connect the dots between those groups helps to bridge that gap. I think sometimes in the absence of information, people make up their own stories of why things are happening. And so I think about connecting those dots is really helping to talk about the why. Why do we do things that we do, or why don't we do things that we do? And then how do I bring clinical nurses into that discussion so that they are part of the solutions? Because that's, I think, when we get our best solutions. So for me, at the end of the day, being successful is really engaging the frontline staff and giving them a voice and being able to then shine a light on the work that they do on behalf of the organization. And that creates alignment.
Awesome. Thank you. Dr. Seniors, are you able to pick up on those threads? Because I'm hearing connecting those dots. How do you do that in your role of chief nurse, and how does that define success in your role?
I agree 100%. Thank you so much for the question. In terms of the why, for me, it's making sure that our frontline staff understand the why and our leaders understand the why. And both parties have to be in it for the right reason. So success for me right now in the middle of this pandemic and the unknown is transparency, communication, team accomplishments, staff empowerment, quality initiatives, patient experience, patient safety, throughput to ensure that we are able to level load right now throughout our system to ensure that we're able to accommodate patients. Right now, as we speak, we are seeing increased patients into our emergency departments because of COVID-19. So making sure that we can provide for our patients. When I took this role about 2.5 years ago, the focus was to improve the healthcare delivery of over 1 million New Yorkers. I would say that that is still my definition of success, but I think now it's really to be agile and to ensure that all leaders are also agile in our approach and that we're communicating as much as possible with our frontline staff. Thank you.
Awesome. And if any of our panelists want to join in, just feel free. Dr. Curtin, I'm wondering in your role at the university hospital, how is success defined in your area?
Sure. So thank you again for that question. And I agree with my colleagues in terms of engaging frontline staff in success, in the CNO success, because we can't do it without our frontline staff. And we also remember, and I often remember this often, something I read in somewhere in my MBA with something that defined what a successful leader is. And I think about that often as I do my work. And I remember that's going something like, successful leaders engage for impact. And I think about that all the time. That's what we have to do. We have to impact the patients and the staff that we work with, that we adapt proactively. And certainly I know all of my colleagues here know that every day is different. There's not one day that I walk into the office and what's on my calendar is a plan day gets changed by something that's occurring within the organization or some new initiative. And I have to learn how to adapt proactively and think through, what works best for both the patients and the staff. And the last thing I think, and all of us, I'm sure all the CNOs on the panelists can agree with this, that we have to deliver reliably. People set expectations for us, not only our bosses, but our patients and our staff, and we have to deliver on those expectations and deliver on them reliably. So I think those three things that I always remember is keep in the back of my mind as things that are important to me and my work in terms of delivering outcomes very successfully.
Thank you. One of the goals for our discussion today, we have a range of nurses or a range in their career in terms of their leadership career. We also have clinical nurses who registered for this event. So one of our goals was to inspire not just future nurse leaders, but perhaps help current nurse leaders envision themselves as future chief nurses. So to that end, what should early career nurses do to prepare for that role? And I'll start with Dr. Sinius on that question.
I am a passionate, avid believer in education and professional development. I think that all nurses should continue to learn at all points of their career. For example, myself, I just recently completed a fellowship program, a postdoctoral fellowship. I'm in the process of completing a second fellowship because I really want to keep my finger on the pulse on what's happening locally, nationally, and internationally. And so I really believe that education is key. I have been very fortunate to work for some of the best nurse leaders ever. So I do think that all nurses should really identify a nurse leader that they can learn from, and also, if possible, identify a mentor. I recently read an article, it was written by Deloitte. It was actually a Deloitte consulting article that said, oftentimes employees who stay with their companies greater than 5 years, most likely, twice as likely, have had a mentor. So 68% had a mentor versus 32% that did not, who stayed with their employers for greater than 5 years. And so I think it's so important that mentorship is happening within the walls of all facilities for nurses and for those who want to become nurse leaders. I believe mentorship is instrumental. I've done it. I still have multiple mentors. And so I would implore all future nurse leaders to identify a mentor and to continue learning.
So just a little follow-up question. Is there a difference between a mentor and a sponsor, and do we need both?
I would say yes, there is a difference between a mentor and a sponsor. I actually also have sponsors who will sponsor me for certain programs, but are not necessarily mentoring me on a day-to-day basis. So I do think that it's important to understand the difference. I also think it's important that if an individual would like a mentor, that they are an engaged mentee to ensure that they're also contributing to the experience and to the relationship.
Mm-hmm.
Ms. Pando, did you want to add to that? Oh, I think you're on mute. You're on mute.
I'm sorry. Thank you. I wanted to follow up on Natalia's comments, that spirit of curiosity, and I think Carl also, adaptability. They need to really think 5 years out, set goals for themselves, pursue educational experiences, as Natalia said, and also be open to opportunities that perhaps don't fit the box or what you thought was coming. Be open. You don't need to be 100% prepared for what you think you're ready for. I think adaptability and flexibility is key at this point.
Awesome. I think, and Dr. Albert, you're muted.
Okay, let me try that again.
Oh, actually, Debbie,
So why don't Yes,
Okay, let me try that again.
Yes,
Now,
I,
can you
that's
hear
what.
me?
Yes, yes.
Oh, great. So what I was just going to, I wanted to tag on to what Terry said about saying yes to opportunities. I would say also, and don't wait for the opportunity to come. So if you know that you want to advance your career and that you want to try leadership or going further into your leadership career, I would say seek out stretch opportunities. Don't be afraid to try something new and ask for that opportunity, especially if it's a low risk for failure option. You know, having mentors and sponsors, they want you to be successful as well. So don't be shy in seeking out opportunities. And I will tell you, there's no leader that would ever say no to somebody that raised their hand and said, can I try something? So don't be afraid to seek out opportunities.
Thank you.
I also want to just comment on that. I love Dr. Albert's concept of stretch opportunities. Think outside the box, right? If you've been a critical care nurse all your life, you know, that's not the only world, and that's not the only area that you can seek an opportunity. Think about ambulatory, think about OR, seek out those stretch opportunities. There's in my own organization, there are leaders that have been doing the same thing for a very, very long time. And I talk to them a lot about, you know, maybe you need to not think about doing something different, you know, to advance your own career. So always look for those stretch opportunities. Sometimes it might mean you need to leave the organization and go someplace else and maybe come back. So that's another way you can advance your career.
Yeah.
Thank you for that. So I'm just going to pivot a little bit. You know, through the course of this discussion, we'll be talking about a range of topics, and I want to leave time at the end for our audience to ask some questions as well. So I'm just going to pivot a little bit to talk a little bit about the visibility of nursing in the public space. So in the early days of the pandemic, the president created interdisciplinary committees to oversee the federal response to the impending health threat. We saw a number of CMOs invited to participate in these committees, but the nurse leaders were largely absent. So I'll start with Ms. Pando. I'll ask you, do you have any advice on how nurse leaders can be more visible in local, state, and federal steering committees?
Absolutely. I think it's a tremendous responsibility that we have right now. First of all, I think we all need to have the courage to have a presence on social media. And that's something myself I'm working on with confidence. And by the way, Renee's push as well. You know, we have to be out there. We have to be visible. We need to seek social events where politicians are present, introduce ourselves, you know, be out at community events. We're talking about diversity and equality and inclusivity. This is how it happens. And I think we have a very serious responsibility to include our frontline nurses in any opportunity to bring them along with us. We need to be stronger in this respect. To your point, Christy, you know, we need to be side by side with our chief medical officers.
Thank you. Anyone else want to join in on that? I recall when that committee was launched and announced, and the uproar in the profession where, because we didn't see any nurses. Subsequent to that, I think because of the uproar and the fact that nurses were glaringly absent, they were added later on. But initially, that they were not the first people that they pointed to. And Terry, I'm working on that as well in terms of being more out there with social media. It can be challenging, you know, with all of our responsibilities and all the things that we have to do on a daily basis. But I agree with you, definitely making sure that we're out there as registered professional nurses, nurse leaders who are leading the practice, to show that we do have things to say about what's happening, not just with healthcare, but what's happening with the world, and be more thought leaders out there. And have more of a presence. So thank you for that.
You know what? I think most of our systems have global health leaders, global health programs. We should be bringing those speakers to our hospitals. We should be exposing our nurses to missions and different things like that. I think it's an area that is just wide open for us.
I think so too. I think nurses struggle with how do I get involved? I remember during the pandemic when I saw Dean Eileen on the news, I was so excited. But the reality is there was a recent article written by Lewinsky and Simmons that states 1/3 of nurses are involved in public policy and advocacy. There's so much opportunity. And I think to Terry's point, it starts with thinking about how do I contribute to my community? What am I passionate about, whether it's helmets or, anything that you can think about locally or getting on community boards and really getting comfortable in that setting. And then post having a local effect, a national, and then, taking it from there. But I think nurses struggle with that. And I think that's something that we can start really embedding within the academic setting to get us comfortable in terms of what does that really look like.
Sure. And Natalia, you make a very good point. I think we have a lot of students here on the call today. And one of the opportunities that you could take advantage of is look for board opportunities. Natalia mentioned that a little bit, whether it's a community board, whether it's a business board, whether it's a hospital board. We need more nurses serving on board. So look for those opportunities. And that's a great way to influence change at the local or global level.
Ms. Panda, you mentioned diversity, equality, and inclusion. So earlier this year, the newly updated Future of Nursing report was released. And the report outlines the ways in which nurses will need to adapt to the needs of society with a strong focus on the social determinants of health. And the committee believes that health equity can be achieved through strengthening the capacity and expertise of nurses in this area. So Dr. Senius, because you work with New York City Health and Hospitals, I'll start with you, and then any of the panelists want to join in and provide a response. What are some of the ways that nurses can ensure equitable care for all patients? And perhaps you can talk to our audience about the organizational responsibility in this area as well.
Sure. So in my role as Senior Vice President, Chief Nurse Executive, I'm also the co-chair of the Equity and Access Council for our entire system. And so within that role, we're working on workforce diversity, workforce inclusion, equity and access, and also monitoring and evaluation. So we're doing a lot within the equity lens, even looking at equity within all of our performance improvement projects across the system. But when we think about the Future of Nursing report, I'm really excited about this report because we're tackling every aspect of the report, ensuring that nurses really understand what social determinants of health really are, understanding that I can impact whether or not a patient is successful in their medication regimen once they go home. And so we're doing a lot. We most recently signed an agreement with CUNY to establish an equity forum. And so we're kicking it off in January to really educate our front line about social determinants of health, the terms that we're hearing now, to understand population health and what can a bedside nurse or a leader really do to integrate those elements. We graduate from nursing school oftentimes, and we have social work services, care management, and oftentimes new nurses don't understand those roles. But now we're finding that it's also within our role as a nurse. And so we're doing a lot. We know this for those in practice that discharge starts at admission, right? But now we really have to understand, what does that mean once my patient gets discharged so that they do not come back to the hospital? And so we're redesigning our work, our care delivery model here in the way that we work. We're also doing a lot, as I mentioned earlier, to collaborate with social work services and our Vice President of Population Health to really ensure that, again, that we're integrating this within our nurse leader rounds and also our care delivery model within our nurses. But we're really excited about it, and we're really putting action around each bullet of the Future of Nursing report. Thank you.
Kirsty, if I could just add, as I have started to read the report, it just struck me that in many ways, this is a return to our roots or a call for us to return to our roots. Because when you think about how our profession started, it really was an evidence-based start with an epidemiology look, but really collecting data, understanding, and then evaluating the impact of our practice. And so I think of this as to how do we measure the impact of our practice and know whether or not the things that we do bring value and or are creating inequitable outcomes. And so in so many ways, I feel like this is a call back to our public health epidemiology roots so that we're measuring the impact of our practice and ensuring equitable outcomes.
Yes, it did seem like for a time, healthcare in general moved towards specificity. So there's a specialization of every single body part, every single nuance with a focus on acute care. So there was a discussion or move to ambulatory, and now we're talking about community care. We're talking about the social determinants of healthcare. So I do see, to your point, there is that ebb and flow of where we're focusing our healthcare efforts. And it's really, like you said, going back to the roots.
I mean, nurses have been dealing with social determinants of health. We just didn't call it that.
Yes.
For our entire career. What better workforce to handle this? Maureen White, our nurse exec for Northwell, had her annual nursing retreat this year. And the theme was, the challenge was, how do we get our frontline nurses involved in improving the access and equality of care? And I had an emergency department staff nurse who knew we were doing social determinants in the admission profile, right? Every nurse is doing it, helps to identify for the patients. This nurse started her own small survey for the treat and release patients in the emergency room, asking about social determinants. It was amazing. As we've said before, the solutions lie with them. And it was just an excellent little experiment that she did. Very, very satisfying. And yes, even those patients were embarrassed to even discuss it so easily. So it's a challenge we need to solve.
Thank you. And so, Dr. Curtin, I'll pivot to you a little bit, and I'll change the nuance of the question. So when we talk about diversity, equity, and inclusion for our patient population, there's also diversity, equity, and inclusion as a discussion point for our workforce. And so in your role, how do you influence diversity, equity, and inclusion in the work environment for the caregivers, to make sure that the caregivers are reflective of the populations that they care for?
Sure. So to start, as you know, I'm the chief nurse at University Hospital. So I will tell you that I have a very diverse workforce, right? From people, all cultures, all races. So I'll start there. We measure that and we monitor that on a regular basis. But I'll give you another example of how I influence diversity and equity in my workforce, in that I'm mostly a baccalaureate prepared workforce, about 85% baccalaureate. But I have a community college right in my backyard that prepares nurses. And often the only way that people from this community can gain entrance into the healthcare field is through a community college education. So I save about 20% of my positions for the community college prepared nurse. I know that, it's critical because that's the only way that some individuals from the community can gain entrance into the workforce. So I make sure that I hold some positions for the community college prepared nurse and help them gain entry into the workforce. And we actually pay tuition for them to go back to school to get advanced degrees. So that's one way in which we continue to work on our diversity issues for the workforce at my hospital.
That's great. Thank you. Anyone else want to join?
As in my role as co-chair of the Equity and Access Council, we do a deep dive in statistics. And right now at Health and Hospitals, we're looking at increasing our Hispanic nurses and also our Caucasian nurses to ensure that we have equity across the board. And so I'm working with the Department of Education to really start educating youth in junior high school, not high school, because we realize by the time an individual is in high school, they know what they want to do, believe it or not. And so we're working with the Department of Education to really inspire Hispanics to become nurses, and looking at creating different pipelines with CUNY as well to increase overall demographics of our nurses. So a lot of exciting work. From an equity perspective, we're also looking at race-based assessments. We most recently started a program called Medical Eracism to abolish the assessments based on race. So we're doing a lot in that space, whether it's kidney function labs that are ordered because someone is Black, really taking a look at, what is in the medical orders that might lead to inequities. So a lot of exciting things happening here at New York City Health and Hospitals within this space.
Thank you.
I think it's exactly right. It starts with the hiring process and ensuring you're bringing in a diverse workforce, but then it's also providing mentorship and succession planning opportunities so that then we have a diverse workforce at all levels of the organization. And so, I'll just say here, we're really fortunate because we have a Myers alum that this was her DMP project, was creating a mentorship program specifically focused at underrepresented minorities. And so we've been able to take that as a seed of a project that then we've got a work group focused around that here, because it really is then how do we provide additional growth opportunities so that our frontline workforce looks like our community, but our leadership also looks like our community and our workforce. So I think it's intentionally providing succession planning opportunities as well.
So we were going to do Q&A at the end, but it just so happens there's a question in the chat about increasing the number of males or individuals who identify as male into the profession. So I figure I'll just pose that question and perhaps there might be some thoughts around that. And if not, we could always come back to it.
Yeah, we're doing that as well. So we just started a nurse leader work group across the system where we have 11 work groups. And we're also looking at men in nursing to ensure that we are inspiring our incumbent staff, whether they are EVS, housekeeping, and supporting them to become nurses as well. And so we're looking at that. We realize that we do not have enough men in nursing and they need to be supported. We do have a lot of male nurse leaders, which is fantastic, and male CNOs. But we're doing a lot of work to ensure that they're empowered and they are also supported.
All right, thank you. All right, so let's pivot a little bit and let's talk about a really super hot topic right now, which I know everyone was waiting with bated breath. Let's talk about the state of the nursing workforce. So earlier this year, Razzo, Fitzpatrick, and Maziak published an article in the Journal of Nursing Administration entitled "Nurses Intend to Leave Their Position and the Profession During the COVID-19 Pandemic." And the paper cited the following statistics. 11% of the nurses surveyed intended to leave their position, 20% were undecided. Nurses who rated the pandemic's impact at the highest level had higher intent to leave their position. Less than 2% indicated that they were leaving the nursing profession, whereas 8% were undecided. So the paper went on to conclude that because of these findings, which have been validated in other studies, the organizational attention to nurse well-being, work environment, and staffing is imperative. So these statistics have been validated by numerous studies, and we're seeing this phenomenon at our own organizations and in other industries outside of healthcare. So Dr. Albert, I'll start with you on this question by simply asking for your thoughts on the instability of the nursing workforce. And as experienced nurses resign, transfer, or retire, and new graduates are onboarded to take their place, how do you deal with the resulting loss of knowledge and skill?
So what a timely question. I'll say I've been at this long enough that I've lived now through a couple of nursing shortages. unfortunately, but this one feels very different for so many of the reasons that you said. And as you cite those statistics, it's just so sobering. And I would tell you from my perspective, I believe that we're going to be in a period of instability now for a couple of years until the dust settles. In many ways, I feel like the pandemic has just laid bare, though, some of the underlying issues that have been going on with the nursing workforce for quite some time. We've had some, I would say, tectonic shifts in that, we've all moved to these 3 12-hour shifts. So our nursing staff is with us less than they are not with us. But also as hospital employers, when you think about it, we flex them up and we flex them down, and we float them here and we float them there. So we have treated our nurses like such a commodity at some level by this flexing and moving. And so I think that fundamentally the nurse hospital or nurse employer relationship is different than it used to be. And I think that the pandemic just caused nurses to step back and think, wait a minute. And so there's so many options for us as nurses, what to do with our time and our expertise, that we're seeing really experienced nurses making all sorts of different choices. It's putting a tremendous burden, I'll just speak at our organizations, on our experienced nurses that are here, because we've been very fortunate in that we can hire a ton of new grads. But as you point out, Kirsty, that really then creates this group of experienced nurses that are really now trying to onboard, assimilate, mentor all of these new grads to teach them really what it means to be a bedside nurse with all of the complexities that it is. So I think we're going to be at this for a while yet. I do think it's going to be a couple of years before it all settles out, but I am hopeful in that. I also think it gives us as nurse leaders a great platform from which now to drive some change in the way that we engage with our nurses. And I mean, we, the organization, the way that we engage with our nurses and treat them as the true professionals that they are. This is a topic I could talk a lot about. I'm going to stop so that my colleagues can add their voice to it. But I'll simply say we don't ask the orthopedic surgeon to scrub into brain surgery when his case cancels. So the fact that we ask our nurses to float all over, it's an opportunity for us.
Absolutely. I'll leave that open because I'm sure others have things they'd like to say about that.
Sure, I think I agree with Dr. Albert on that. I think we've got to embrace the fact that we are going to be with a staffing shortage for a while now, and we are beginning to think about what's new to help with that staffing shortage. And so one of the things I think, I was excuse me, I was very proud of the fact that, pre-pandemic, if I had 10 agency nurses in my organization, that was a lot. But now I have a lot of agency nurses, and I think that's the new staffing model. And I think all of us as chief nursing officers are going to have to embrace that. Agency work is going to be, one of the things that we have to accept, that they're going to be the folks that are going to staff our hospitals. And so particularly with the rates that they're charging now, and people are jumping at that particular opportunity to make some quick money, particularly the millennials in my organization. They don't have the same level of commitment that they had. All of us have been doing this work for a very long time. The millennials are jumping at the opportunity. In fact, it's funny because I was just looking at some recent data. There's some folks in my organization that left to go work in the agency, and I'm hiring them back through the agency, right, to work for me through the agency. And I think that's the reality of what we're dealing with today. I was interviewing someone else today for another position, and that's coming from another agency, and they're going back from an all RN staff to putting LPNs back into their organization. I'm not there yet, but I think we've got to start we're going to have to start thinking about new, different, maybe old again staffing models.
Yeah.
I'm not saying anything that we haven't heard of before, so it's not really new and innovative, just how we did business many years ago.
it is disheartening. That's the word I use. It's, every day you hear of another resignation. You know that this is across all of labor because you're talking about the Great Resignation. But for us in nursing, kudos to Deborah for her insight that, nursing is an exquisite workforce that we probably have not listened to over the last many years. It's a very difficult situation. We're trying to capture, we're all doing this, I know, trying to capture that, med-surg or tele-nurse that might rescue us for our ICU and ED vacancies. We've had some success with that recently, but then you've got 10 or 12 telemetry vacancies, which is what I'm dealing with right now. It's very difficult. We're talking about alternative models, but the key point is it's probably not going to be to replace a nurse, but there will be less nurses. And that's the risk and the worry. How do we bring that to our staff, particularly in the face of the new staffing councils that we're all, preparing, talking about every day. I just think it's a very odd confluence time right now that this is all coming together. That discussion at the staffing table is going to be very, very different than I think we all thought it would be 6 months ago when we were encouraging shared governance and the use of a council. It's going to be fascinating.
I will tell you, I just came from one of my hospitals to do rounds to talk about the upcoming staffing committees and just to talk about staffing in general. And all they wanted to talk about was recognition because of COVID-19. It was really interesting.
Really?
They said, we have staff, but we want to be recognized Nurses Week every week. And I think we need to be innovative from a staffing perspective, but I think we're going to really have to convince our nurses to stay. And that may be more than just staffing, but thinking about literally recognizing them nonstop for the work that they do. One nurse was close to tears because she did not think she would have a holiday party because of social distancing, because she wants to be recognized, right? We think about social distancing, the holidays, but it's the little things, I think Deborah said this earlier, to get our nurses to stay and thinking beyond staffing models. I do think that we're going to have to partner with our finance colleagues to take a look at the way that we staff, to think more about per diem roles. I think Carl mentioned the different generations. We need to talk to them. What will get you to stay? I mean, if you think about 10 vacancies and the cost of those vacancies, we need to look at the salaries. We need to think that the 3-day, the 4-day work week may no longer be the answer. It may be 1 day a month. I mean, that's what we're dealing with right now.
Yeah.
And so I think we're going to have to really recreate the way that we staff very soon, quickly.
But I think that as we become more and more flexible with the way that we staff and with all of these new grads, I've been in conversation recently, how do we then as leaders really ensure that our processes are the safety net so that the less experienced nurses as well as the experienced nurses, it's the same outcome. And at least I'll say, I believe that there's no replacement for experience, but how do we provide through all of our processes then that safety net for the patients? Because I think that's going to be our challenge. We've had the luxury of stable staffing for the last several years, and now we're seeing what that looks like when we don't. The other thing I want to just build on what Natalia said also about the recognition. I think it's also part of the re-recruitment of our staff is helping them heal from COVID. And so focusing on well-being and resilience and how do we help our nurses. And now this is nurses at all levels of the organization, our nurse leaders as well. How do we help them heal and feel whole? And, I know, Kirsty, you've heard me say this a lot recently. And how do we make it okay that nurses attend to their own needs? Because that's something we don't typically do. But I think that's so important as we try to work through the healing process, which I think will help with retention as well.
And I think we're all challenged with that, how we talk about balancing professional and family life, we talk about offering alternative models of care, but in reality, we're all talking about and thinking about it. It's, I guess to Natalia's point, we need to go to the staff and acknowledge the effect that COVID has had on them. And really, I know in our budget development, we keep saying, oh, COVID's going to be, we're going to plan, you know, with just a little bit of COVID. No, it's what has the impact been? And this is the result we're feeling every day.
Yeah.
I also think potentially we hear about, we know now about COVID long haulers, patients who have had COVID and now they have the long-term sequela of COVID-related symptoms. I do believe that the reason why we're hearing that is that there is also COVID long haulers for the caregivers. So there's that long tail of going through all the iterations of the emotions and figuring out what happened. So sometimes for our nurses, they don't even know that they're in that long sequela while they're in it. And so it's not until after the fact that they're able to look back and say, well, last month or a couple of months ago, I was feeling X. Oh my gosh, that's as a result of what's happened over the last year and a half. So I think, you know, Dr. Seniors, when you're hearing that, is they're still registering and realizing that the things that they're experiencing now that they may not be necessarily readily attributing to the effect of having to care for patients during the pandemic, they're only realizing it after the fact. And so they're still talking about it. We have COVID long haul patients, but we have COVID long haul caregivers who are still experiencing that effect.
I also think, Christine, we as nurse leaders, we have to keep our fingers on the pulse on workforce in general. Part of the conversation I was having with frontline staff today was about support services, dietary, EVS, lab techs, et cetera, and thinking about the Amazons of the world and their increase of salaries, their ability to make more money in different areas, working remotely, and how that will impact our support services for our frontline. So, you know, keeping in mind the fact that, you know, the annual salaries of a lot of these positions or the rates, hourly rates are increasing, and what are we doing within healthcare? There was a recent article in the Harvard Business Review where there were 800,000 healthcare jobs, but they were only able to fill 200,000 of them because there's just a shortage and everyone's going to other you know, occupations and other professions. So we need to think about that as nurse leaders, not just our RNs, but all of the different you know, titles and positions that support us or will not be available to support us, because as we all know, that impacts our workforce environment.
I mean, I'm impacted that way. The RNs were holding steady with, as you said, Carl, with agency help, but the PCA support, I just don't have it for them. And that, you know, that they feel that is a pressure that they feel, particularly with a couple of COs or, you know, very acute patients on the unit. I almost feel like that's a great force right now on them, on the stress, creating that stress.
Yeah, I want to extend on what you said, Natalia. As an executive team, we're looking at salaries across the entire organization because we have, you know, environmental service workers that could literally go to Amazon and probably make more money than they could working in, you know, our facility and in terms of their hourly pay. So we're looking at all of those particular issues because those roles are critical to support the staff and the nursing staff and the work that they do. And we want to also make sure that they're compensated fair, equitably, and adequately. So, you know, we're looking at the entire workforce within our organization and, you know, and how we, you know, support the nursing staff.
Yeah. We've chosen to start to look at a career ladder for our entry-level unlicensed personnel so that they feel like they've got a long career with us, or they could have a long career with us, with then some career growth and progression to areas of more responsibility. So trying to make it really a value for them to work with us, even if they come in at the entry-level roles,
what's a path forward for them. So I think we have to think long-term as well.
So I would just want to just mention to our audience, if you do have questions, feel free to put them in the chat. I do see a couple of questions in here while our panelists talk about their strategic initiatives around retention, wellness, building health and resiliency, and re-engaging our nurses back into the practice. Perhaps if any of you want to talk about that a little bit. You know, we do see, and then this has been, it's not recent, it's not new, where we'll have newly licensed registered nurse come into the practice and within a year, year and a half, 2 years, move on to other things. And is that a trend that you believe will stay? And, or do you think that there's an opportunity to re-engage the clinical nurse into the practice where they see that as a place where they would like to be as part of their career?
So I don't remember who mentioned, but I think one of the things that one of my colleagues mentioned is that we have to have the support structures within the organization to support the nurses. During COVID, I was very fortunate to have a D&P student who did some resiliency work, and the outgrowth of that work is that we have a team now called the We Care team that and it gets a lot of business. What they do, they get calls from people who are just trying to cope on a day-to-day basis. They just need support. They just need an ear. They want to talk about their experiences. And so I think now that team is up to about 6 or 7 team members. And so, they get calls all the time. At the same time, prior to COVID, we had a healthy workforce initiative where we had a consultant that was working with my team and me on changing culture so that we had a healthier workforce. We dealt with things like bullying and incivility and emotional intelligence, and we had workshops and management coaching and a whole host of activities around that. And after COVID, we got busy. We really got busy using her services and supporting not only the managers, but the staff. We've now initially started as a nursing department, patient care services initiative. And so now she's in finance and she's in environmental services and in food service. That's the need that it was felt throughout the organization. So we've got to continue to support the nurses and listen to the nurses. And as Natalia said, give them credit and show our appreciation. And so we've been doing that work full force because staff are hurting and staff want to talk about their experience and staff want to be supported. So we've got a full core team working on just that part of that resiliency work.
Could I pivot a little bit? So we've been talking about our clinical staff and non-clinical staff. I want to talk a little bit about caring for our leaders. Perhaps some of you want to talk a little bit about the work that you're doing in your organization to care for our leaders, because in order to do the work that we're talking about with our clinical staff, you've got to have a resilient leadership team who are themselves engaged, who remain passionate about the work, who want to do this. They're humans too, and they experience COVID as well. They're experiencing the same COVID long haul symptoms, if you will. So what are some of the things that you're doing in your organization around caring for our nurse leaders?
So at New York City Health and Hospitals, I think, there we go. At New York City Health and Hospitals, we actually created the title Chief Wellness Officer during the pandemic. And we partnered with our new Chief Wellness Officer to conduct wellness retreats for our nurse leaders across all 15 of our facilities/areas. And during these wellness retreats, we had special messages from celebrities, but we also had opportunities to create a safe space for leaders to talk about what they went through and what they're still going through. So we had nurse leaders that were ill and that were out. And it was really emotional. But it was great. You know, we provided them with wellness kits, lavender oil and eye masks. We really talked about the importance of PTO for nurse leaders and ensured that they all got a break during the wave 2. And that was really great. And we saw our nurse leaders doing the same thing for frontline staff, which was really interesting after we held these wellness retreats. But I think just calling it a wellness retreat was very refreshing to give them that opportunity to say, wow, I can take a deep breath and just talk about what I've been through and what I need as a nurse leader to reflect on the past year. It was really remarkable.
We've been doing something similar, though maybe not quite at the scale that you have been. But we actually started with, first thing was just focus groups for our nurse managers. And what we initially thought was going to be just a focus group or two turned into then ongoing support groups. And some have preferred to just have really small groups, and some come together in a little bit bigger groups. Those actually we're fortunate that we were able to partner with our psychiatry department to help us with some of that work as well, because we knew that it shouldn't be facilitated by senior nurse leaders. We wanted especially our frontline nurse managers to be able to have a safe space to talk about that. And then we've run a few cohorts of a narrative medicine series, which is just gives our leaders a chance to come together. It is really looking at the nursing practice through art, though. So it gives them the opportunity to just think about their work in a very different way. And so it's really about return to purpose, but in a non-stressful, creative manner. And we've gotten really positive feedback around that. So we've created a nursing leadership role on nurse wellness and resiliency. And she's just starting to put together some programming, but some of that quite intentional for our nurse leaders, in particular our nurse managers, because they really bore the brunt of so much during the pandemic. They had the staff there. They were dealing with new teams as we were redeploying staff every day. So they were trying to put together teams on the fly every day. So they have a lot of healing to do as well.
And all this recruitment and retention challenge is falling on them as well.
Yeah,
I feel almost every day they're getting calls from recruiters, move fast, move quickly. You've got 24 hours, make a decision, do this, do that. I'm really listening to both of your ideas, because even planning a holiday party presents challenges given the concern about COVID coming back. But I think I need to take a firm stand and say, no, we still need to do something for this group.
Yeah, I think that's critical. And so, yeah, I mean, I'm celebrating with my managers and directors. I think it's just critical. I'm trying to get it in before we can't do the celebration. So, so I think that's critical. They've had a hard, last few years. And I think that staying connected to them and celebrating with them is critically important. And also my organization, one of the other things we do for not just for leaders, but for staff, after COVID, we designed a wellness room, and that's a nice space. Waiting for the furniture. It's stuck someplace. And so the door will open. Yes.
Supply chain woes.
Yeah.
So there's a question in the chat. Have any of the panelists used non-traditional methods of communicating with staff? For example, podcasts, Clubhouse, blogs. All the panelists have a tremendous amount of experience, some of which can be incredibly valuable to staff, direct care, and leaders alike. Great question.
That is a great question.
I have a question. Do our panelists know about what Clubhouse is?
No.
Okay,
Yes, I was on Clubhouse.
I figured Dr.
I don't know that. I don't know either. So
I do. It's cool.
Clubhouse is pretty cool. Yeah. So I'll open that up for you all to answer. Have you used non-traditional methods of communication in your work?
Non-traditional, no. I think that's a great idea. I'm actually starting fireside chats, but it's not real fire, clearly. But I know so many of our nurse leaders, they have coffee with the CNO, but I'm starting that. But I really want live communication, because I think it's so important so Clubhouse is actually a great idea. but something, or even a podcast where employees can actually tune in. But I wouldn't want to blog. I've had a blog before, but I would want something where I can really hear their responses and really respond. But thank you for the great ideas. I never thought that our nurses could actually join Clubhouse. Now I'm thinking.
And now I'm thinking too, I'm going to write that down, Clubhouse.
Yeah, I'm going to learn that as soon as we hang up.
So Clubhouse is cool, but now you know who the cool panelist is as well. The only one that knew what it was.
Right.
In all honesty, I heard it from my daughters. I personally have never laid eyes on it. I just heard it through kitchen chatter. Okay, that was a great question. I don't see any others. I think we answered, actually through the discussion, we answered a number of the questions that are in the chat. I do have another question for the panelists, because again, we have nurse leaders on the call, on the live, who are new nurse leaders, potentially possibly aspiring to be chief nurse and nurse leaders in the future. What brings you joy? What keeps you going? What wakes you up every day? What brings a smile to your face and a light in your eyes?
For me, that's simple. That is improving care for the communities we serve. It sounds cliche, but it's real for me. I took my job because I took my sister to the emergency department many years ago when I was not in this system. And I found that the wait was too long within the system. And I thought I can make an impact. And we've actually worked on throughput in that emergency department. And so to think that I can impact the care of the communities of which my family lives, and to really have an impact on public health during this public health crisis, to me, is not a job. It is something that I do every day effortlessly because I love it so much. So I say, follow your passion and you will know, because you truly will not have to work a day in your life. I absolutely love what I do, and I respect the mission and the vision of the organization that I'm working for.
Thank you. Anyone else?
I would say what brings me joy is when nurses talk about the work that they're doing. So when I round, one of my favorite questions to ask is, tell me what you're working on, or what are you proud of? And boy, when you just see nurses light up, and again, this is at all levels, leaders as well as frontline staff, they just light up when they talk about the impact that they made or the improvement on their unit, what their unit planning council is, improvements that they've put into place. So for me, it's just so joyful to watch others light up and be proud of the work that they're doing, whether it be a small change of practice or something that's big. It's just so fun to watch other people come alive as they talk about the impact that they make. And so seeing others on fire, because then you know that that spreads. And when you can get a whole team that's like that, it's just fun to come to work. So yeah. I agree completely with Natalia. When it's fun to come to work, you're not really working.
Absolutely.
And the biggest joy I have is getting out of the office and walking around the organization and see, the nurses in action. And as Deborah said, talk about their work and the joy they get out of work. That gives me joy to see that they actually enjoy it. So every day, as I said, every day that I go into work is a very, very different day. I love the problem solving. I love the involvement of nurses at every level of the organization. There's nothing that happens in an organization that's not impacted by nursing or for through nursing. And so it just gives me joy to be out there and watch the nurses do the work that they do, and that we as leaders can support that.
I feel the same way. I mean, that is when your day is just not going well and you make rounds and you have that kind of experience, Deborah, there's nothing like it to restore that joy and feeling. The other for me is seeing a new leader chosen who was the right choice, and to watch them grow quickly and fast, and to see their successes. That really, it makes me so proud to be a nurse when I see that kind of growth and support that they get from other people.
Thank you for inspiring our future nurse leaders. We have a couple more questions in the chat. Any tips on traversing failure? We learn from our mistakes, but it still carries a sting with it and can often fester and impact mental health. So any advice on how you deal with failure?
Well, the
in
first
your
thing I think you have to do is you have to think of failure differently, right? Failure just means you got to go back and rethink it. That's all. If you don't try, you don't know whether it works or it doesn't work. So when you fail, it just means go back and retool it. And so that's how I deal with failure. It just means I got to go rethink it and think it in a different way. And so failure is an opportunity to grow.
I agree with Carl. I'm a very process-oriented person. So oftentimes I think about what is the process that I use to then change it so that I can have a different outcome. But I think we just have to not to get religious, but I give myself grace and I allow myself to just learn from the mistake. So it's realizing that these things will happen, but how do you learn from them?
Yeah, I was going to say, first, I would say, get over yourself. Everybody makes mistakes. So, you're not the first one to make a mistake, and you're not going to be the last one to make a mistake. But, it's similar to what Natalia was saying. For me, it's about having a reflective practice. And so reflecting back when things don't go well, but also if you've just got a baseline reflective practice, and then when things do go well, also reflecting, gosh, what did I do that worked there so that I can repeat that as well? So you're human and you're going to make mistakes. We all do.
Absolutely. And we tend to be our worst critic. So that failure tends to outshine all the really great things that we did in the past. So that would be the little piece I would add to that is, there's probably a lot of stuff you've done really well. So try not to focus on that negative, focus on those positive outcomes. All right, a few more questions. These are great questions. Are there tools or materials you invest in for nurses that support them at the point of care in light of COVID? So this sounds like they're talking specifically about tools, resources that were implemented specifically to handle COVID patients. And I probably can think of a few myself, but I'll let you guys answer that. Did we do anything differently in the practice environment?
I would say utilize a lot more, sorry, there's an echo, a lot more applications during COVID. So a lot more mental health apps for 24/7 counseling. So we had a lot of anonymous counseling, particularly in the emergency department, where staff would call 24/7. So a lot more apps were definitely used. And as we all know, everything changed in terms of policies. And so we posted everything on our internet, but it's constantly changing, right, with the CDC. But we took all of those guidelines and really made them available to staff and pushed them all out, recognizing that they would all just change, but trying to communicate as often as possible is what we did.
Okay. Anybody else want to take a shot at that?
I do want to say, and I'll just spin it a little bit. A lot of what we, in terms of tools and materials that came out of COVID, actually came from the staff themselves. And when I think about things like, I remember very early during the first wave of the epidemic, the nurses were, created a way for the IV tube, all of us experienced with the IV tubing coming out the door of the room. Yeah. And then I think I walked around one time, I said, guys, you can't have it on the floor. It can't be on the floor. And then they went back, they rethought it. And then they came back and said, Dr. Curtin, you got to come up and see what we did. And then it was beautiful and it was fantastic. And it became the standard of care, right? I remember very early in the epidemic, when we were very, very short staffed, the nurses came up with the idea of disaster charting. They told me that this is what we should do. And in terms of, this assessment or not doing this assessment. And then we came up with this whole disaster charting tab in Epic. And now we have that when we get into a crisis, we know we can switch on disaster charting and everybody knows what that is. And so, but these are the things the nurses came up with. And all we had to do as leaders is listen to them. And they're the ones that came up with the innovation.
It's a great idea. Now on that topic, there's a question actually in the chat about trends in nursing informatics. So that sounds like one trend
Yeah.
that came in light of COVID. Any updates on that? Any information on that?
A lot of trends in nursing informatics. We actually recently held our annual nursing informatics conference. So last year it was focused solely on COVID, and this year we talked about the lessons learned. So whether it was how do we onboard expeditiously to ensure social distancing, looking at technology, looking at our applications for nurse scheduling systems to ensure that our agency staff are all on the same platform. So really leveraging our nurse informaticists to also look at disaster documentation. When do we turn it on based on volume? When do we turn it off to ensure compliance and to ensure that we're also keeping up with the Joint Commission regulations and also and all other regulatory agencies. So our nursing informatics partners have been just wonderful, and they're nurses. And so it's really giving them the opportunity and the platform to really showcase how we can improve technology. And that was really interesting during the pandemic.
We held documentation burden focus groups, to get clinical staff to let us know where is the duplication, what are their frustrations. We weren't able to change all of it, but kind of became an agenda to set what are our targets to achieve this and this and this. And it's still going on, and it's quite an active project. And I think they feel that they're engaged. We don't have Epic, but we have Allscripts. It's not as responsive, but there's been great improvement. We just had an upgrade this week to assist with some of the guidelines and plan of cares, which is always frustrating. But we have an obligation to work on those things and identify what the staff is dealing with every day.
I think also part of this is our use of alerts and disruptive technology as well. And how do we reduce that so we reduce the cognitive overload? So we're having the opportunity now to have those discussions of why do we fire that alert? And what do we expect the nurse to do about that? So I think that the pandemic did just raise awareness of some of the cacophony that had been going on. And it's now given us the opportunity to start to question all of that. And so I think how we use this opportunity is up to us, but it would be a shame to miss that. The other thing I would say as well is how do we use the technology to support the nurses rather than the nurse having to be the interface to multiple systems, because that's the current state in a lot of different ways. How do we use the technology to support the nurse differently? So you have to sign on as a primary nurse in your CMC and then a secondary nurse. And so it's a good opportunity now for us to really use the technology differently.
Okay, so it's 8:20. I'm just doing a quick time check, and there are 3 more questions in the chat. So I think that's going to be our last 3 questions. And it looks like they're 3 very different. So the first is, what can nurse educators do to help, I guess, chief nurse officers or executives achieve your goals the goals that we talked about tonight?
Well, I think they're a very valued part of nursing leadership, and we don't always, not everyone thinks of them as that way. So they have to be at the planning table. They have to be rounding with staff, doing the same things that we're all doing, and bring that feedback to the table to be front and center to the staff. We can't do it without them. They're critical partners.
I agree, Terry. Nurse educators to me are the foundation of everything that we do. During COVID, we trained over 10,000 nurses.
Wow.
In terms of curriculum, we actually had our Council of Nurse Educators conduct a SWOT analysis to tell us how are we performing, and all of their responses in terms of weaknesses, opportunities, and threats we used to revise what we were doing for all of our staff. And so I think they are key, they're integral, and we're also short of nurse educators, in the practice setting. From an academic perspective, I also think they're key to help us with preceptorship programs, to ensure that we can retain our new nurses as well. And so we're doing a lot here with nurse educators in the academic setting and also in the practice setting.
Yeah, I would say, right, it's that partnership of the academic educator and the clinical educator. And how do we competency and skill assess quickly and in the same manner so that we aren't, as we bring on new grads, reteaching, which is sort of crazy when you think about that. So how can we competency assess in more similar ways so that we can get our nurses out into the clinical setting where they actually will, I think, learn and where they want to be faster, as well as I think that from the clinical educators, we have a lot to learn from the academic educators as far as ongoing competency assessment and education as well. So, you know, practice is never stagnant. So how do we continue to refresh and look at the way that we're competency assessing?
I just want to add, they are our heroes. I don't think we could not have done it without them. Love our educators, need our educators. They're essential workers for us.
All right, just a couple more questions. Would any of the panelists like to share an example of a stretch opportunity that he or she took on maybe early in their leadership career and how it played out? Sounds like somebody's taking your stretch assignments to heart.
Yeah. So sure, actually, I'll start since I said that. You know, as a clinical nurse, I was a medical and then geriatric nurse. And one day my manager called and said, hey, you got to come into work early because the CNO wants to talk to you about your career. And I worked 3 to 11. I didn't think the CNO knew me from a hole in the ground. And so she said, you know what, I think you should try managing the epilepsy and acute rehab unit. You know, the last nurse manager for the rehab unit and the medical director didn't get along. He's really difficult, but I think you should give it a whirl. Okay, so it was a stretch in that I didn't know the first thing about epilepsy monitoring and epilepsy nursing, nor did I know the first thing about rehab nursing. So I had to jump in and learn the clinical practice so that I could talk with the medical director, who was difficult. But it was a little bit of don't say no to an opportunity, but I knew I wanted to advance my career. And if I didn't learn this quickly, that probably could have been the end of my career there. So it turned out okay, but you know, you just have to take a risk, and I knew I could work hard. And so I had confidence that my hard work would pay off at some level.
I think I've had a number of stretch opportunities in my career when similar to what Deborah said, you know, one day the CNO said, oh, can you pick up this service or can you do this? And you pause for a moment. It's like, well, I really don't have an interest in that, but you just do it and then it becomes okay. And then you learn that service and it keeps growing and growing. My career started off as a critical care nurse. And if you said to me that I was going to be a CNO one day, I would have laughed at you because I was the critical care nurse, you know, the typical critical care nurse, involved in everything, knew everything and did everything. And then one day somebody asked me to take a leadership opportunity and then it blossomed from there. So just take a look at those opportunities. Don't say no, don't be comfortable. And sometimes you just got to step out of your comfort zone and do something different. You never know where it's going to lead.
You know, I talk about those moments, I call them tap on the shoulders. And I often talk with my leaders, you know, the strong leaders who are good at it. That is a recognition tactic that is so important. Hey, have you thought about this? Have you thought about being an assistant nurse manager? Some people don't even think of themselves in that light. And that is a tremendous responsibility we have as leaders to raise that question or make them feel good about themselves. So I think that's one of the most important things we do.
Well, I can certainly say that the first time I ever thought about nursing leadership was when someone else suggested it to me. Up until that point, I had not a single thought about nursing leadership until they actually said it. And I said, might be something. So yes. And the final question is, What made you sure you wanted to pursue the leadership route, and what makes you confident in yourself? And we'll close on that last question.
I think it goes back to the what brings you joy question, right? That if you, as you were mentoring people coming up in your career, as you were precepting perhaps a new graduate, those, for me, those moments, I knew that that influence was something that I wanted to pursue, and it made me, I was proud to be part of that growth. So for me, that's how I felt that that was the right direction for me.
Very similar for me, Terry. I would say for me was really goal setting and accomplishing goals and learning everything I could in every role before I felt ready to move to the next position. And so it's learning as much as I could and feeling that I was ready and really gauging my readiness per se, myself and my mentors at the time. But I think it's really learning as much as you can to feel confident. I've always never taken another role unless I really felt I understood every aspect of the previous role.
I do want to say that don't be fooled, because there are times when I'm not confident, there are some days, I look confident, but, sometimes it's very hard to get there. So, we're not perfect leaders. I don't think any of us could say that, we make mistakes, sometimes you go home and say, did I make the right decision? Did I do the right thing? Confidence is a very funny thing. I know we may look confident, but it's not always true. So, you develop your own sense of style, and I think that sort of comes off as confident, but there are days that I question myself and things.
Well, Dr. Albert, Dr. Sinius, Dr. Curtin, Terry Pando, thank you so much for taking time out of your very busy schedule to be with us here this evening. This was absolutely wonderful. Thank you for being transparent and for being vulnerable with our audience. And I'll just take a second to say, time for an applause, virtual applause. Thank you so much. This was wonderful. We're getting a lot of comments in the chat saying that this was really a great event. And I'll hand it over to my fellow alumni, Alexa, to close.
Hi, thank you. Thank you, Kirsty, for the introduction and for moderating the event tonight. As our event is coming to a close, I would like to take a moment to say Dean Eileen Sullivan Marks apologizes she could not be with us tonight, but she does send her best. I would like to thank all of our panelists for this incredibly thought-provoking discussion. You have given us insightful thoughts and opinions about current issues and trends in nursing and healthcare at large. We appreciate your time and support of NYU Myers. Lastly, thank you to everyone who attended tonight. The college will be hosting the annual Estelle Osborne Legacy Celebration on February 24th, and we hope to see you again at this event. We hope everyone has a safe and healthy holiday. Good night and see you soon.
Thank you.
Thank you.